First Talk with Hal Rowe, 7 till 9, weekday mornings on 1290 WHKY.
First Talk with Hal Rowe, WHKY Talk Radio.
Good morning. Welcome back to First Talk with Hal Rowe on 1290 WHKY Talk Radio for the Greater Hickory Metro. It's American Heart Month. You need to find out more about what's going on with your heart, find out the best way to keep it healthy. We're going to talk this morning about different aspects of heart health and heart health care with Dr. Brian Herron. He is an interventional cardiologist with Hickory Cardiology. And as it was being explained to me this morning, and thank you very much, kind of the plumber. You're the guy who take care of the pipes, all the veins and arteries all around the heart. Is that correct?
That's correct.
Thank you very much for joining us this morning. Good to see you. We got a lot to talk about, so thanks so much for taking the time.
Thanks for having us.
You're more than welcome. Also this morning, Dr. Tom Wiley. He's an electrophysiologist, I guess that's the way to put it, cardiologist. The electrician this morning, if you will. Both of these physicians with Hickory Cardiology. Again, we thank you very much for joining us this morning. First of all, let's talk about heart health in general. I want to kind of give everybody just a general idea of what we're going to be talking about this morning and keeping the heart healthy. Dr. Herron, if you had one piece of advice just to give people this morning regarding a healthy heart, get to see you on a casual level, get to maybe go out and play golf or come over to the house, not to see you in the office. What's the number one piece of advice that you would give someone who's listening this morning?
Exercise and watching the weight. Obesity is becoming a huge epidemic in this country, and along with the obesity, we're going to see a rise in adult onset diabetes, which will also then increase a person's risk for heart disease.
Okay.
So exercise and watching one's weight is going to be the next big push and what we need to focus on.
Very good. How about you, Dr. Wiley?
I would echo Brian's statement. I'd say 5 days a week, half hour of exercise to the point of being a little bit breathless for each and every person who's able to do it.
We just had Sarah Paulin, nurse practitioner, just a second ago, and we talked about smoking. I was a smoker for a number of years. I guess that's another one of the big things, too, is smoking.
Absolutely. Number one, controllable risk factor for heart disease.
Let's find out a little bit about you, Dr. Wiley. You're from the area originally. Tell me a little bit about yourself, if you don't mind.
I grew up in New Hampshire,
okay.
And it's very cold up there, as you know.
Right.
And, my wife and I moved down here after I retired from the military in 2005.
Very good. Thank you for your service to our country, sir. Your undergraduate education, I guess, done part of that came through the military? Is that right?
It did. I went to West Point undergraduate, went on to the military's medical school, which is Uniformed Services University, and then did all my training at Walter Reed Army Medical Center.
Wow, Walter Reed, I bet you saw a lot there, did you not?
It was a sad place to be in 2005.
I could imagine so. Well, thank you for that. As well, not only just the service to your country, but that extra mile of being there. And we're glad to have you. Glad to have you in the area in this nice warm weather. It's been a very mild winter so far, so we've been lucky. Dr. Herron, let's find out a little bit about you. And of course, you're from the area originally?
I was born and raised in Jackson, Mississippi.
Okay.
It's where I went to college, Millsaps College in Jackson. Then went to medical school in Jackson as well, the University of Mississippi Medical School.
Okay.
And then I did my internal medicine training in Toledo, Ohio, and my cardiology training over at Bowman Gray in Winston-Salem.
Great. Well,
so then we came here in 1983 and established Hickory Cardiology.
Oh, really? So you're one of the folks who brought Hickory Cardiology into being, huh?
Yes.
That's fantastic. Well, we're glad, like I said, to have both of you this morning. First of all, Dr. Wiley, I know that we're going to you're going to have to leave early, a little bit early today, so I'd like to talk with you, if you could, about electrophysiology. And you said the electrician. You help me understand these things. You must have heard. Talk to him like, he's in fifth grade and not doing that well in fifth grade, because an electrician, electrician really helps me out a lot. Help me with what they're called EP studies or electrophysiology studies, and that's your area of expertise.
Correct.
Let's talk a little bit about that and about what that means to us today in heart health, how that relates to us as either heart patients or people who want to find out a little bit more about staying healthy.
Okay. Well, a cardiac electrophysiologist is a cardiologist who's got an extra year or two of training in managing heart rhythm problems. So we deal with when your heart goes too slow or goes too fast. And so EP studies are used to induce rhythm problems in patients who have symptoms suggesting those rhythm problems. And then we can go on and fix a lot of those rhythm problems with ablation. The other aspect of what we do involves implantable devices, pacemakers and defibrillators. Pacemakers for patients whose hearts go too slowly for them to feel well, they're passing out or they feel weak. And then implantable defibrillators for patients who are at risk for sudden cardiac death.
Now, I guess these are intermittent problems, because normally if we have a problem when it's beating too slow or it's going too fast, and we have this on a constant level, we get hooked up to an electrocardiogram. Is that what it's called?
Correct.
And it shows what's going on there, and we don't need a test. We don't need an EP study. The doctor can say, oh, your heart's beating too fast or it's beating too slow, and this is the reason, and we're either going to need to do surgery or have an implant or a medication, I guess. Is that right?
Yeah, correct. Very often these things are present in the background consistently. But but even more frequently, they're episodic. So a patient comes in, you might be able to tell that they're at risk for having too slow of a heart rate by looking at their EKG, and then lo and behold, one day they pass out, come to the emergency department, and the heart rate's 20.
Okay, gotcha. Now, sometimes when folks have heart problems, they're sent home with a little device, and then you say, "Now wear this for 24 hours and go to sleep with this. Sleep with right."
Yeah.
You know, if you ever want to stay up for but you're supposed to sleep with them. You're supposed to, and I guess is that part of your study as well? Does that give you a little bit of background before you go in and actually induce the condition that you may need to find out more about?
That's correct. That's one of the non-invasive ancillary tests that we can do to try to catch a rhythm problem. So if a patient says, gee, I have these symptoms every day, we would use a 24-hour monitor. If they say, gee, I have them once a week or once a month, we might use a 30-day monitor. So we have different types of tools for different types of patient complaints.
Now, you say that's non-invasive, and of course, maybe somebody's heart skips a beat. Maybe they're working out on the elliptical, and all of a sudden their heart rate goes way up, and then it comes back down to normal. They notice it on their heart monitor. This is a kind of case where maybe you can't catch it all the time, or maybe you don't see it on the monitor. This is the kind of case where we would go in and we would do an EP study. And we'll talk more about that EP study, your area of expertise, when we return. We're talking this morning with two cardiologists, Dr. Brian Herron, interventional cardiologist with Hickory Cardiology, as well as Dr. Tom Wiley, electrophysiologist cardiology with Hickory Cardiology as well. More First Talk right after this. Good morning. Welcome back to First Talk with Hal Rowe on 1290 WHKY Talk Radio for the Greater Hickory Metro. It's American Heart Month, keeping your heart healthy, keeping you living longer and happier, being able to have a great life and to be able to enjoy it longer. We were just talking about that during the break. Joining us this morning, Dr. Brian Herron, interventional cardiologist with Hickory Cardiology, of course, works with the Fry Regional Medical Center, and we're going to talk a little bit more about the actual plumbing part, the actual parts of the heart that help the heart continue to remain healthy. I don't know a lot about it, but I know you're going to be able to help me with it. I guess a lot of stents are where you come in. Is that right? And a lot of those things that keep the blood flowing. Like a plumber would keep the pipes free at my home, and the clean water coming in, and the bad water going out. I guess this is one of the things that your area of expertise.
I would like the analogy that I use to my patients quite often is if you have to think of the heart like a car engine. You have a fuel supply, you have pistons, you have valves, you have electrical wiring circuit.
Right.
So when you have a problem with the fuel supply to the heart, that can lead to chest pains, angina, or could lead to a heart attack.
Right.
And so what we do is we diagnose what's going on with a patient when they present with chest pain. Is it something related to the heart or not?
Right.
Is it a problem with the plumbing, so to speak, to the heart?
Right.
And if it is, how bad is it, and what's the best way of dealing with it? Be it either medicines, a balloon procedure, including a stent, or possibly bypass surgery. And
we'll talk about those a little bit later on this morning. I want to thank you very much for joining us. Dr. Tom Wiley We were talking about electrophysiology before we went to the break. The electrician, if you will, Hickory Cardiology, of course, associated with Fry Regional Medical Center as well. Let's talk a little bit about the EP studies, because we talked about that when we went to the break, before we went to the break. There's an underlying cause. We may have an accelerated heart rate, a low heart rate. We have these symptoms. We maybe not catch it on the 30-day monitor or the 24-hour monitor that we're able to. We might not find it on the electrocardiogram, but you will actually go in and help me with this. Am I right? Cause the problem?
Yes.
Not cause the problem, but cause it to present itself so that you can study it.
Yeah, uncover the problem.
Uncover. There you go.
Might be a better way to put that.
Not cause the problem. Uncover the. Thank you for that, sir.
Yeah. Let's say a patient comes in and they've had a heart attack before, and they have decreased heart pumping function. So because of that scar on their heart, they have not normal electrical conduction of electrical impulses through their heart, and let's say that patient passes out. Well, I know just from statistics that those patients are at increased risk for sudden death. So we might want to try to induce a heart rhythm problem that if I can elicit that, you could argue that that patient passed out because of that heart rhythm problem. Because in most people, you cannot elicit that dangerous heart rhythm. And therefore, we put one and one together and say, gee, you probably passed out from this heart rhythm problem.
Right.
We probably ought to treat that heart rhythm problem.
Okay, so you will actually go in and as part of the uncovering of this problem, you may be, if a patient has AFib, which I've got.
Correct.
They may have it every now and then. You will actually go in and try to stimulate the heart or have the heart go into AFib so that you can study it and look at it?
AFib would be an exception to that rule because that's usually picked up just on EKG.
Okay, gotcha.
And I can pretty much get anybody into atrial fibrillation if I try hard.
Really? Okay,
Yeah,
gotcha.
It may not sustain, but I can get them into it.
Okay.
Other types of more organized heart rhythm problems, most patients are not susceptible to.
Okay, and then you're able to take a look at those. You're able to study those. You're able to find out what's going on with the valves, what's going on with the plumbing, if you will, with the different chambers. What's the word I'm looking for? The valves. You're able to see some of these things happening?
Well, that's a different study entirely. The electrical system is an entity to itself.
Oh, so you're just studying the electrical system and what's happening
you
there.
You can have perfectly normal valves, even perfectly normal heart pumping function, but still be at risk for some rhythms which are more of a nuisance and some which are life-threatening.
Very good. Now, how do you correct these? Is a lot of this medication? Once you discover or uncover the problem, is it medication? Is it, I guess, pacemakers is what you'll deal with, or some of the other different things that go on now with being able to maintain a proper rhythm in our heart?
It really depends on what the underlying cause of the heart rhythm problem is.
Sure.
A lot of these heart rhythm problems can be treated with ablation, which is...
What is ablation? I hear that all the time. I hear people talking about ablation, or they had to go in for ablation. Describe that to me if you could, briefly. Like I'm in fifth grade and maybe not doing so well in fifth grade.
Well, let's say you have a problem where your heart races.
Okay.
And this is a very common problem in young patients. Even.
Sure.
During my time in the military, we'd get patients shipped in from Germany who had symptoms of, all of a sudden my heart will just take off and go 250 beats a minute.
Right.
And we bring them into the EP lab, get them into that rhythm, and most often that's a benign type of arrhythmia.
Okay.
And we would then put catheters into their heart and track down where that rhythm is coming from.
Okay.
And burn that spot.
Okay.
And then
you say burn that spot.
Burn it.
That's so you're talking. I mean, we're talking about just the normal. And what do you, I guess do you use a laser, just a hot catheter? What do you use? You're actually burning heart tissue.
Correct.
That's pretty spooky. If you hear somebody talking about ablation, that's pretty spooky. But you guys do it all the time, so you pretty much know what you're doing.
I hope so.
Right.
Yeah. It's a controlled burn.
Okay.
The tip of the catheter is usually about half a centimeter long, and we just pass radio frequency energy through it that causes resistive heating, and it basically coagulates the tissue, much like you see take a drop of egg white and put it on a hot stove. It contracts and turns white.
Sure.
Same kind of thing. We don't have any any flames in there. It's
Right.
very, very controlled.
Very, very controlled, and very, very small. This
It is
gonna
very
be,
small.
And I guess that you're getting into some very small areas. Is that right?
You have to be pretty specific
Right.
in some of these ablations on where you're burning.
'Cause you wanna
Otherwise,
make
you're not
sure
gonna
that-
have success.
Right. Now, is that part of the EP studies? Does that track down where you want to do the ablation? Is
That's
that part of the
correct.
study?
Yeah, we do the EP study as a prelude to the ablation.
I'm not a medical student, of course. Didn't stay in a Holiday Inn Express last night. Don't know much about this. Where does the electricity come from in our heart? Is it a static electricity? Is it electrochemical? Help me with where the electricity that we're talking about comes from.
It's electrochemical, actually. It has to do with movement of sodium and potassium ions. That
So it's
are,
chemical reaction starts
It is
there.
a chemical reaction. Your
Okay.
body can generate electrical, very, very small. These are not
Sure.
large electrical impulses, but by moving sodium and potassium to opposite sides of a cell wall, you can create electrical gradients.
So this obviously is maybe somewhere the medications come from. If we're taking a look at
That's right.
okay, that was going to be my next question, because ablation I understand and it's very helpful, but I'm not so sure I want to go through that. So sometimes you can look at the the chemistry and the electrical part of the heart and say, well, maybe we need a pacemaker, or maybe we need medication, or maybe ablation is not what we need to do. You can do this?
Correct, yeah. Medications are a great option in the majority of patients who you really don't want to go straight to an invasive procedure with all of its attendant possible risks
Right.
which can occur.
Now let me ask you this: someone's having a increased heart rate. Someone is maybe has a slow heart rate. They get a little dizzy. They're driving. They don't feel so good. Your recommendation is: do I visit a cardiologist? Do I go see my primary care physician? What's your recommendation for that?
Well, if you know that your heart rate's really slow,
Right.
like let's say you're driving down the road and you take your pulse and you feel lightheaded and your heart rate's 30, you probably ought to go to the emergency room to be
Okay,
perfectly
very
honest.
good. Emergency room first.
And,
Okay.
and they'll get in contact with us 24 hours a day, 7 days a week. We're there to help you out.
Right.
But if you're just a little woozy, then you probably should start out with your primary care doctor, because there's
Okay.
a lot of cause of transient lightheadedness that aren't related to the heart. And so
Okay.
you give your primary care doctor a visit, and they can start out and try to delve into your symptoms a little bit deeper and
And
refer
then
you on.
I guess then the primary care physician will maybe recommend us, if it's necessary, to Hickory Cardiology, or the patient may say, I want to go to Hickory Cardiology. I know Dr. Heron, good guy. I want to go see Dr. Heron. And then you guys will get over there. Dr. Heron says, well, maybe we want to see Dr. Wiley first. I mean, you guys will make that ascertainment once inside the building, right?
That's correct.
Okay, very good. I know you've got to run, but I want to thank you very much for joining us this morning. Thanks for the information. Learned a lot this morning, and hopefully our listeners learned a lot. And maybe if they hear that word ablation, maybe won't be so fearful. Maybe be able to go in and get that problem taken care of. And that's one of the things we like to do here, is to put those fears to the side and let them understand that y'all are the professionals. You're going to take good care of us. And thank you very much for your time this morning. Again, thank you for your service to our country, sir.
Well, thank you very much, Hal. We appreciate the opportunity.
When we come back, we're going to be talking with Dr. Brian Heron. He is an interventional cardiologist, Hickory cardiologist, Hickory Cardiology, and he's going to be talking this morning about some of the different aspects of the heart. Actually, one of the founders, if I'm not mistaken, of Hickory Cardiology. More First Talk right after this.
Online, on demand at WHKY.com.
Good morning. Welcome back to First Talk with Hal Rowe on 1290 WHKY Talk Radio for the Greater Hickory Metro. Dr. Brian Heron joins us this morning from Hickory Cardiology. Of course, works with Fry Regional Medical Center, interventional cardiologist, the plumber, if you will, to kind of help me and then continuing that analogy. Dr. Heron, thank you very much. Now, of course, Mississippi, home for you,
Yes.
but Bowman Gray and Winston-Salem, and then came to Hickory and actually started Hickory Cardiology. Did you find that there was a need in this area for cardiologists? How does a practice start like that? Let's kind of start with that. That's just personal curiosity.
When I was doing my training, at the end of the training, it was time to decide where to go practice.
Right.
And it was apparent that Hickory had a need, and they were far enough away from Charlotte, Winston-Salem, or Asheville to be able to develop an identity and not be in the shadow of those really major medical centers.
Right.
And so that's why we came to Hickory. Before we came here, there was no cardiac cath lab. We were the first board-certified cardiologist to come to this area and be able to practice heart catheterizations, and in addition to all the non-invasive testing of stress tests and echocardiograms, et cetera, that had been available here, but we brought in cardiac catheterization. It was a battle. We were the communities in Charlotte and Winston, particularly Charlotte, were pretty anxious about a cardiac cath facility being developed here. But we were able to fight through that at the state level and got approval to set up the heart catheterization facility at Fry.
Okay.
In 1985 is when we first started doing heart catheterizations there.
And this
in
is through
October
Fry,
1985.
right? Okay. Now help me with heart catheterization. I hope I'm pronouncing that correctly. Versus an ablation, because if I'm not mistaken, catheterization, doesn't that deal with heat and burning or something like that? Or is that wrong? I've heard of that. Someone's maybe I've got the wrong word there.
Well, with the heart catheterization, the way we would describe it, we're passing hollow tubes up to the heart so we can measure pressures inside the heart and also then inject dye into the main pumping chamber of the heart and also the blood vessels that feed the heart.
Okay.
Doing electrophysiology tests would be a form of a catheterization because you're passing a catheter, but it happens to be
catheter. I'm thinking of
catheter.
Cauterization. Okay, catheterization. Right, catheter.
So
okay.
Dr. Wiley passes electrical catheters up to the heart to measure electrical currents.
Okay.
And we're passing hollow tubes to inject dye and measure pressures.
Now, sometimes those catheters, is that right, will remain there, or is that like a stent? Is a stent a catheter that remains in place, or is a stent different?
A stent would be a bit different. When we do a stent, we need to have a roadmap. We need to inject dye into the arteries to see where the problem is.
Okay.
And then when we establish where the problem is, we'll pass a very small wire down the artery that has the blockage, then over that wire pass a catheter, a balloon catheter, that typically has a stent crimped on the balloon. Wow. When the balloon is inflated, it will expand the stent, and the stent stays behind to serve as a scaffold to reduce the risk of the blockage coming back.
So the stent actually kind of expands and then stays in place.
Yes. If it wasn't crimped on the balloon, we'd never get it in the artery. It'd be too big.
Sure, gotcha, okay.
So by crimping it on the balloon, we try and make it as small as possible so that it can be delivered to the appropriate spot. The stents now are typically coated with a drug, a medicine, to reduce the risk of the blockage coming back, because whenever you do something inside the artery, it sets up a scar tissue response. You're injuring the vessel.
Okay.
And that was the real problem with balloon procedures early on, before stents came out, is that you would stretch the artery.
Right.
But in the process of doing that, you would injure it. And so you had an increased risk, at least 33% of the blockage coming back.
Is that because of the scar tissue?
Some of it was the scar tissue. Some of it was called elastic recoil. You'd stretch the artery.
Right.
And then when you pulled out the balloon, the artery would start to shrink back down.
Okay. Gotcha.
So you had two different reasons for the blockage to come back following a balloon procedure. When we put in the first stents that were not coated with medicines, it would pretty much solve the issue of recoil, the artery instantly wanting to collapse. But it did nothing to solve the issue of the scar tissue response.
Right.
So the drug coating on the stents helps alleviate that problem. And so now the risk of the blockage coming back with a drug-coated stent is probably less than 10%.
Wow. Is that the biggest advance that you've seen since you've been working as a cardiologist? Would you say the stents? Was the other one called angioplasty? Is that what that was called?
Yes.
The balloon? Okay.
Well, when we got to Hickory in 1983...
And see, I don't think that's that long ago. That's just me. I think 83 is yesterday, but there's been probably so many advances since 83.
Before 1983, the standard, most heart attacks were taken care of by giving the patient morphine and waiting for the smoke to clear in a day or so. And if the patient survived, then you found out how much damage had occurred, and you really did nothing to modify or change the outcome. So when we got to Hickory,
That's
1983,
83. Wow.
we started giving drugs, streptokinase specifically, clot-busting drugs to
Okay.
dissolve the clot. And we were able then to reduce the amount of damage to the heart. The patients were much more stable. They became pain-free, but it wasn't universally successful.
Was this the
About-
Coumadin and warfarin that was done back then as far as clot busters, or different drugs?
These were much more aggressive drugs.
So just weren't blood
more like-
thinners. They were aggressive drugs to go ahead and bust the clots.
kind of like Drano for a clot.
Thank you. Okay.
And the problem with these drugs is they were only about 70% effective.
Okay.
So you had a significant number of people that did not respond to the medicine.
Okay.
How would you know that? Well, they would still have pain. Their EKG would not improve.
Okay.
And when we say they would not respond, it's time sensitive. Time with a heart attack is muscle. So the faster you get the artery or the heart attack dealt with, the more heart muscle that you can save. And that's why it's so important when people feel like they're having a heart attack to call 911 and get attention for it. So that's what led us to do later on heart catheterizations
All right.
for the acute treatment of heart attacks, because we found that the outcomes were better,
Right.
that patients then, instead of having a 70% chance of the blockage coming back or having relief of the blockage, that it was 95 to 99%.
Wow.
The problem with using a clot-busting drug is it dissolved the clot but did nothing to treat the underlying blockage. So if you went from 100% blockage to after being given these clot-busting drugs, you may still have a 80 to 95% blockage present because you still have the cholesterol blockage that hasn't been dissolved.
Right.
So
And that's
where
only the
stent-
30% that are going to react to the 30% that are going to react to the medication.
Well, 70% respond, but you still have the blockage left.
Gotcha.
30% never open up at all.
Right. 30% that never open up at all. Okay.
So that is the advantage of a balloon procedure during a heart attack, and that's what we have developed as a statewide protocol called the RACE protocol.
Okay.
It was started out of Duke, and we're very happy to be participants of that here in Hickory, where we have now established a routine, so to speak, of how to treat heart attacks.
Now, is this the STEMI race? This is what we were talking about
This
before?
is the STEMI RACE program.
Okay, that's an acronym, of course.
It's an acronym for ST elevation myocardial infarction,
Okay.
STEMI. And Fry Hospital is the only hospital in this area that does STEMI care 24/7, 365. On the weekends, at night, we have dedicated cardiologists and staff that take care of patients. So we are the referral center for the Unifor to take care of heart attacks.
So if I got the chest pain, I got chest pain. I'm feeling, I've been out to say, well, it would be nice if we were shoveling a little snow, maybe. But shoveling snow, all of a sudden I get the chest pain. And there's something wrong. So I call 911, take me to Fry. I want to make sure that just to take me to Fry. I go over there. Then they do is the first thing they're going to do is they're going to go in maybe after they determine. I guess an EKG is the first thing, right?
Well, that is the beauty of the RACE protocol, is that we have now given the paramedics, and the first thing you said was the most important. I called 911,
Right.
as opposed to driving yourself to the hospital.
Oh yeah.
The paramedics will come out and do an EKG in the field.
Really? Okay.
And they can transmit the EKG to the hospital, but they are also now being trained. That's the beauty of this RACE program. It's not just hospital-centered. It is also, we recognize it as a team approach with paramedics as well, and the emergency department and the cath lab. And the paramedics can look at the EKG and make a determination of whether or not it appears to be a heart attack. And instead of going to the closest facility, say if they're in Burke County,
Right.
if they feel that it's a heart attack, they will proceed directly to Fry.
Really? So they're
And
able.
that
That's the
saves a
STEMI
lot
race
of time.
program. Instead
Yes.
of going to the other hospital saying it's a heart attack, we need this done at Fry.
Yes.
They take them right to Fry. Okay, more First Talk right after this. Doctor. That's very interesting. Thank you for helping me understand that a little bit more, because now we can go back in and we can take a look at the, when we come back, we'll talk about the way that we put in the clear the plumbing, if you will, medicate the area, and keep it from happening again. More First Talk right after this. Good morning. Welcome back to First Talk with Hal Rowe on 1290 WHKY Talk Radio for the Greater Hickory Metro. Dr. Brian Heron, our guest this morning. Hickory Cardiology, of course, works with Fry, interventional cardiologist, and we were talking about the STEMI RACE program, the importance of getting to the emergency department if you've had a heart attack, and finding out exactly what's going on. And then the word I was looking for before we went to the break, being able to get that catheter in there, being able to, and I guess at that point, discovering more about what's going on with a heart attack, finding out where the blockage is, being able to put the dye in and being able to go through that part first. Do you do the ascertainment when you come in with the STEMI RACE program? Ascertainment a big part of it?
Yes. So when the paramedics will make a determination out in the field that somebody's having a heart attack.
Through the AKG and through their training.
Yes. They will call that in.
Okay.
And at that point, the clock is running.
Okay.
We're on the clock, so to speak, because we have a time that we have to get the patient into the lab as quickly as possible. And all of these steps are monitored as part of the RACE protocol, so we know how long it took from the time in the field to get to the emergency room,
Okay.
how long it took to get from the emergency room into the cath lab,
Okay.
and how long it took from being in the cath lab till the time we open up the artery.
Okay.
And all of those things are tracked, and we have on every case. And so we constantly strive to improve that. We're looking constantly to figure out where the bottlenecks are.
Okay. Sure.
Why did it take too long to get an EKG or whatever? And the times that we have been able to demonstrate in our program in Hickory have been excellent. We're one of the best in the state.
This is a statewide program.
This is a statewide program. We go to meetings probably once a quarter where all the data is shared, and we then get to basically hobnob with the physicians from Duke and find out a little bit more about what they're doing.
Right.
So it's a great way to share information amongst colleagues about how we can do this better. And it's not just physicians there, it's paramedics, it's the coordinator at Fry Hospital, April Traxler, who does a great job with this. And
this all came out of Duke.
This all came out of Duke, and we are very fortunate that North Carolina is basically the leader in the country on doing heart attack care.
When we have this in Hickory, and you said for the Unifor area, so those are the different areas that are served. I guess maybe there's one in Winston, maybe there's one in Charlotte. Exactly. You've got one up at in the mountains or whatever. But it's a certain area, I guess, geographically that we can get to quickly.
Correct.
In a certain amount of time to get in there and to get into the cath lab, to do the ascertainment, get into the cath lab, and then get into to opening the areas that need to be open or to treat whatever's going on with a particular heart attack.
So it depends upon what hospital you're at and its distance to a hospital like Fry,
right,
that offers 24/7 heart attack care in the cath lab. That will tell you what the initial treatment is. So if you are an hour and a half away from a hospital that has a cath lab,
right,
then you may be given clot-busting drugs initially.
Okay.
Because time is muscle.
Sure.
If, on the other hand, you're only 20 minutes away from a heart attack center like Fry, then those patients will be brought directly to Fry Hospital, and we will take them directly to the cath lab.
Time is muscle. You're talking about the heart being muscle. You're talking about the different areas being muscle. That's you don't want the damage there, because once the muscle is damaged, am I hearing that right from what you said earlier? Once the muscle is damaged and once that area is damaged, that's a long road back if it comes back?
Horse is out of the barn.
Okay.
So time is muscle. You want to try and get that artery open as quickly as you can to relieve pain and limit the amount of damage. And so that's what we do. We go in with a catheter. If there's evidence of a clot, we'll use a different kind of a catheter to suck out the clot, so to speak. And then we'll pass a balloon and a stent down and open it up.
Right.
And the
then
results,
go ahead.
With a medicated stent typically.
Right.
And it's amazing how well the patients look when they leave the lab as opposed to when they present with severe chest pain. It is very successful, and this is the standard of care now.
After the heart attack, it's American Heart Month. After the heart attack, do you find that people you work with or that you come into after they've been through this, are they pretty much serious after that point of maybe you've told them, hey, you got to give up smoking, you got to lose weight, you got to get some exercise, because you are a candidate for a heart. Do you find they take it seriously, unfortunately, after the heart attack?
Sadly, no.
Really?
It's amazing how many people don't get the memo about stopping cigarette smoking.
Right.
It is tragic when I see patients with severe heart disease, and they may have severe lung disease to go along with it. They may be on oxygen at home, and they're still smoking a pack a day.
Wow.
It is stunning when we have that come in, and quite honestly, it's discouraging. You're wondering, what are we doing here?
Right.
Patients need to take responsibility and understand that sooner or later, Humpty Dumpty is going to fall off the wall, and we can't put Humpty Dumpty back together again. They have to stop smoking.
I've talked with some people, and they have told me that sometimes that is the problem. That we get people who have, it used to be dying from AIDS. Now people are living with AIDS. And maybe sometimes some of that, it's great that the stigma's gone and some of the problems are gone. But yet sometimes maybe people don't take it as seriously. Do you think that maybe we've done the advancements? Bill has a heart attack and he's fine. Ed has a heart attack and he's fine. Mary has a heart attack. And the next thing you know, people rely too much on that technology and too much on the fact that we've got these advancements and don't take it as seriously as they did at one point. Because like you said, Humpty Dumpty, that's a great example. He's going to fall. That's going to happen. And maybe people don't take it as seriously as they should.
They don't. When we came to town in 1983, quite honestly, I think most people felt that if you got referred to a cardiologist, you were near dead.
You're on your way out. Right.
And now, with the advances we've made in treating heart attacks and other things, the risk, the incidence of heart attacks in this country is going down.
But because of, go ahead.
Well, it's because of the risk, the death rate from heart attacks and heart disease is going down. But unfortunately, it's going to plateau and begin to go back up because of our epidemic of obesity and development of diabetes related to obesity.
I want to thank you very much for your time this morning. I hope that we can rely on you to come back and talk with us again. You do an excellent job of articulating large subjects and topics and breaking them down so that I can understand them, and I really appreciate that's a real talent, that's a real gift, and you do a great job at it. I want to thank you very much for joining us this morning.
Thanks for having us.
Susie, if you would, please, let's go ahead and close the way we normally do Monday through Thursday with our national anthem. Thanks so much for joining us on First Talk. We know you have a choice in morning radio. That's why we appreciate you choosing the First Talk radio program. Remember, it's American Heart Month. Take care of yourself. Watch your diet. Watch smoking. You want to make sure that you meet our fine physicians that we talked to this morning on a level not at Hickory Cardiology.